It's perfect.
All right. So should I go ahead and begin?
Yep. Thank you.
Well, all right. Well, apologies for the 1 hour delay, but I'm glad cell phones working just fine. And I sincerely appreciate the opportunity to provide a very brief overview of a very interesting and wonderfully important subject. And Ms. Summer there, I just wanted to make sure y'all are able to see me with the slide share. Make sure my slides are up there, okay?
Yep, it's great. Thanks.
All right, fantastic. Well, again, thank you for having me. I'm here in Atlanta, Georgia, and based on the contact information you see here today, should you have any questions or difficult questions, send them to Summer. Please send me all of the very easy questions. I kid there. But I would like to point out a couple disclaimers here that we are teaching this through the Rural Communities Opioid Response Program grant, and any updates or hyperlinks that maybe are broken, if you'd be kind enough to let me know, and I'll make sure to get any of these items updated. So the core focus that we have here at Archprocoding, the ARCH stands for the Association for Rural and Community Health, and my 27 years in the industry, being able to teach in 49 states, our focus is on the rural health clinics, FQHCs, and critical access hospitals. And so to the point that we are discussing today, documentation, coding, and billing at a high level, especially if we have any clinical folks there, we do want to make a very important distinction that coding is actually turning medical documentation into usable data. Much of that data can be gathered by the substance and opioid use plans that you're a part of, whether that is using CPT Category 2 performance measurement codes, if they're tracking your diagnosis codes to potentially impact the payments that you receive on a per member per month basis. There are a lot of coding activities that are going to be necessary to generate data for a grant, data for a patient that may not have anything to do with revenue. And of course, the two revenue items that I'm putting on the screen are extremely important because of the variability in approaches that different insurance companies have on paying you. So we will often have to use Medicare as the foundation, since they publish their rules extensively. Many managed care organizations, including Medicaid, uses some of their primary billing rules. But when we talk coding and billing, we do want to make sure as much as possible that we do get clinical providers involved as well, so that they're aware of the standards that are out there in terms of how to document according to the needs of the CPT code book, of course, your ICD-10 book, etc. And so we do have a full 4-hour course that I teach that covers the subjects that I'm bringing up here for you on the screen. I'm going to provide a very brief overview of each of these, some backgrounds of providing medication-assisted treatment, some of the documentation, coding, and billing foundations that are out there. One that may be interesting to those of you that are more on the clinical side, and that is that the clinical approach many of your providers use to determine whether a patient has a substance or opioid use disorder does not come from the ICD-10 where we find our diagnosis codes. Rather, it comes from the DSM, the Diagnostic and Statistical Manual, 5th edition. So even when I say substance use disorder or opioid use disorder, those terms, believe it or not, don't even appear in an ICD-10 code. So one of the codes I could put in the chat box here, many of you may have seen code F11.20 as it references opioid dependence uncomplicated, when in fact, by its nature, when we're providing medication-assisted treatment, we have the medical team providing buprenorphine, etc., or other opioid agonists or antagonists, while we have concurrent behavioral health being given. But the idea that opioid use dependence gets certain services covered isn't as important on the clinical outcome side of things, when we do need to be tracking a lot of the patient's coexisting conditions that exist in addition to their substance or opioid use disorder. So I'll go over a couple quick highlights about how diagnosis coding requires us to translate terms the providers use, such as mild, moderate, or severe opioid use disorders, to the ICD-10 codes, which are requiring us to go with either use, abuse, or dependence. Now, in today's session, when we're really focusing on the primary services that your medical providers are giving in relationship to medication-assisted treatment, that really covers a lot of your evaluation management codes. And we had a lot of information last year in the CPT book that is being repeated this year as far as using time and medical decision-making to document your E&M visits, as opposed to worrying so much about the history and amount of exams that are being documented. And then I'll finish very briefly with a couple of pieces of information on getting paid for non-face-to-face visits in our context, talking about distant site telehealth, and some changes that many of us probably had to go through last year and that we'll see continuing through the public health emergency. So not being exactly positive who may be on the line with us, of course, here. These are the primary phases here, your screenings, brief interventions and referrals for treatment, where the patient hopefully at that point provides their consent to undergo medication-assisted treatment. We then determine from a pretty big range of ICD-10 codes, again, what I just brought up, use, abuse versus some of the other terms that the clinicians are using, but your E&M codes are likely going to be common in the induction and stabilization and maintenance phases, depending upon how you're getting your initial patients to come in. Maybe you're performing the screenings and brief interventions at a visit that is otherwise focused on preventive medicine. Maybe it was a problem-oriented visit for low back pain. Maybe it was a behavioral health provider identifying through one of their encounters that the patient may have an issue that requires you to go through the diagnostic and statistical manual process of determining the level of a disorder they may have. So the first set does not require you to use the actual SBIRT tool. If they're using the DASH tool or the Cage Assist tool or other tools that are on the United States Preventive Service Task Force, you can report brief interventions with a variety of codes, and I'll outline them here shortly, primarily using evaluation and management codes plus injection services. But when you're in the induction, stabilization, and maintenance phase, along with tapering the patient down from their MAT treatment, you're going to see a lot of variety on how different payers want you to report their services. That would include using a whole new set of codes that Medicaid often requires from what's called the HCPCS Level 2 code book. And there's actually two sections of the HCPCS Level 2 code book that deal specifically with Medicaid, and one of which is a focus on alcohol and substance abuse. So the tools that you may see me mention here on slide 8, of course, if you needed to research which tools you can utilize and report some of the codes we'll talk about here in a second. The SBIRT tool being primary. When you're reporting those services, you're not indicating the tool that you're using. It's just vital to make sure that the backup documentation is being used on a screening tool that's been approved. So you'll find some interesting items. We have a full 4-hour class. Of course, we're able to dive into that, but you'll see the CPT book give codes 99408 and 99409. As alcohol and or substance abuse. The key there, structured screening based on what we just mentioned, and their time-based codes either 15 to 30 minutes or greater than 30 minutes. But Medicare often creates their own codes in that HCPCS Level 2 code book that in this case have strikingly similar, basically the exact same definition. So if somebody says, Gary, which of these codes do I use? My question is going to be, well, wait a minute. Which insurance company are you billing? Do you have access to their fee schedule? They often may not identify when you report the 99408 or 99409. You just may get denied. But from my almost 28 years, actually, I take it back, yesterday, 28 years in this industry, I've yet to see an insurance company deny a claim and say, man, had you just used those GO396 and GO397 codes, we would have paid you. So we need to be aware of the options that are out there, again, by looking at their fee schedules, by looking at billing manuals. And you'll notice that in the codes at the top, they refer to, quote, alcohol and/or substance abuse. Now, most of the times clinically, when I'm talking with providers, be it through the RCOR grant or our other work, you'll see a pretty important distinction made between opioid abuse versus substance abuse. Please do notice in the top 4 codes on the top of slide 9, you have to assume this is an opioid structured screening as well, where they're using opioids under the umbrella of substance use. But man, I tell you, when we get to ICD-10 code, you have to be extremely careful to distinguish substance versus opioid abuse, okay, and or dependence, etc. But these H codes that are next are, again, alternative codes that were reserved by Medicare only for use with Medicaid. So although you might be reporting some of the services above to Medicare or other commercial insurance companies, this concept that thou shalt, you have to bill everybody the same is factually incorrect. Here are codes and options that different carriers may choose. Again, H codes are only held in reserve for Medicaid use. You'll have to check with your Medicaid carrier to see which they may want to reimburse and on what periodic basis, and by the way, for which types of providers. If you're an RHC or an FQHC, your authorized providers are MDs, PAs, nurse practitioners, clinical psychologists, clinical social workers, but you may have other members of your clinical team doing various parts of these services, and only certain providers might be authorized to report certain codes. So from a contractual perspective, it's important to not only identify, okay, what's payable, which code would they likely want, but also find out if there are any clinical provider restrictions on who can provide that type of care. And if they are not a physician, is it possible that there could be a payment reduction? Now, the codes here at the bottom are annual codes for Medicare that a traditional doctor's office, an RHC or an FQHC can report for an annual misuse screening, or even a brief face-to-face behavioral counseling for alcohol misuse. Again, you may have licensed professional counselors in Hawaii, but they may not be reimbursable for Medicare, but they may be reimbursable for other carriers. So very basic general coding here for the screening, assessments, and brief interventions near the beginning phases there. In addition to your office visits, maybe you're identifying whether the patient has a use disorder during that IPPE, that initial preventive physical, or the annual wellness visit. Heck, it could even have been a general preventive medicine visit, or as I mentioned earlier, was maybe uncovered during a behavioral or mental health visit. So I've listed those codes in blue and giving you an alternate way of looking at these codes, the 99 codes, the G codes, heck, even a G2011, which is identifying itself the same way as the codes we looked at on the previous slides, but now they mention other than tobacco. So do not expect to see a lot of consistency in how different carriers want these codes. Same idea there with telehealth. We should expect to see some varying policies. For Miss Summer, just as a heads up, time-wise, if you could just throw in the chat box when I have about 5 or 8 minutes there. I just wanted to confirm that I'm going to the top of the hour or bottom of the hour. Again, I was watching a little World Cup wrap-up show.
Oh, me too. That was awesome.
I'm glad I gave you my cell there. Good. All right, so those induction and follow-up visits, just like there are not a significant number of codes for treating diabetes, hypertension, gout, or psoriasis, The majority of the codes your medical providers are going to utilize when providing the induction and follow-up visits for medication-assisted treatment will be, as I mentioned earlier, your evaluation and management services. But if you're giving a non-surgical injection of, let's say, buprenorphine, Suboxone, etc., the same code we use, 96372, for injecting vitamin B12 and Synvisc, etc., would be reported. There are codes, a sample of which I've given you here, 11981, which is probably going to become more common down the road, but is not that common now. But it's the implantation of a non-dissolvable dissolvable rod that's placed inside the patient's body, and kind of a time release option that's there. And heck, again, same thing. There are different G codes for different types of formulations, I should say J codes for different types of formulations of medication there. I remind you, as I put this item up on the bottom of 11, that in addition to all those codes up there, there are some options you may want to check out with Medicaid. But of course, if you know Medicaid in one state, you only know it in one state. And those rules and policies are often changing. Whereas my main focus on the induction and follow-up visits is going to urge really careful attention to the ICD-10's official guidelines. You know, when I describe use, abuse, and dependence being different terms than the ones the clinicians are trained on, and most importantly, probably documenting in the medical record, you put a coder often and a biller in a very odd position when they have to choose a diagnosis of use, if it exists. Because, by the way, opioid use codes don't even exist, because of course they can be properly prescribed. But when you start moving into abuse and other ICD-10 codes, it really does impact how long of a program you might get authorized. You use a very unspecific diagnosis like I put in the chat box earlier, you may get a 6-week program covered. If you identify and notice that during your review of opioid use, during the Welcome to Medicare physical or the annual wellness visit, that there are dozens of different types of diagnosis codes that may be more specific and will likely paint a more careful picture of the patient's disorder, especially if there are any psychosocial coexisting conditions that occur, to include what we'll review shortly, are called social determinants of health, Z codes, that are used as a supplement to the primary diagnosis. So what I've done here on the left-hand side, in order to encourage your pharmacists or other care team members that are providing these types of care, that Medicare does recommend that you review opioid use. All my alarms are going off now to tell me to be ready for the Hawaii event in half an hour. So I'm sorry, folks, let me turn off my sound there. On the right-hand side, very, very useful document coming from NAC, the National Association of Community Health Centers. By the way, I did a 1-hour version of our 4-hour class, and NAC usually gets about 80, 90, or 100 people on a webinar. We had over 700 people. So this is clearly an area that's vital. So even if you're not a community health center, even if you're not an FQHC, this is a really great document to help identify how, for example, you might set up internal and external referral processes, maybe setting up a process a day or two before your patients arrive to identify who may need various types of screening. And if you're looking in that document on the right at documentation and coding information, it's going to apply to everybody. It's really when you get to the billing side of things you have to be more careful of, because FQHCs have a very unique billing system and some unique codes that they have. But folks, I happen to write the nation's only certification exam for rural and community health centers. So even beyond what we're talking about here today, feel free to reach out to me after the session if that is appropriate. Now, back a couple years ago, there was some good news there with trying to expand buprenorphine into your communities. We obviously have to deal with training our staff and our colleagues on how to overcome the stigma of receiving this type of care. And looking back at your previous sessions, you've covered that. But there's also been a stigma that providers whisper to me in class and they say, look, I got to be very careful. I don't want to be the buprenorphine provider in town. And so to overcome that, CMS and HHS, I should say, identified the ability for you to get a waiver. Now, I know this sounds goofy, but for those of you providing buprenorphine, of course, your providers had to obtain a waiver that was 8 hours worth of training for physicians or 24 hours of training for PAs and NPs in order to be able to provide buprenorphine. But in the case of this press release, you can actually get an exemption from having to get a waiver. Wait, does that confuse you enough? To get an exemption from having to get a waiver that would allow you to treat up to 30 patients concurrently with buprenorphine, essentially buying you another year for your providers to get trained and able to provide buprenorphine here. But one of the things that I would like to do on slide 14 for those that might be interested in that process, in which case you would be able to then, following the getting of the waiver, move from 30 patients up to 100. Of course, depending upon where you live and your patient volume, that may not be a huge issue. But the source guideline is found here in the second bullet for those that may need a really deep dive on that subject. The third bullet here is really the document that you would fill out to get your provider approved from not having to get a waiver. That should take about 60 days to be approved. And the fourth bullet on slide 14 is a website where you can go investigate that process. There's short videos by this organization called the California Bridge and the Public Health Institute to help you walk through that process. But noticing we have a wonderful set of 80 folks there, let me just drop a little side note here that about a year and a half ago, HRSA and SAMHSA, the Substance Abuse and Mental Health Services Administration, announced that rural health clinics and FQHCs could receive $3,000 per provider for your providers if you're in a rural health clinic or a federally qualified health center, and your providers did receive their waiver prior to January of 2019. So if you're in a rural health clinic and your providers were exempted, they got the Data X or the Data 2000 waiver, you're in luck. FQHC folks, you're out of luck. The money was first come, first serve, and FQHCs pulled all their money out. But as of the my last reading, there's still $1.2 million available for rural health clinic waivered providers to get a $3,000 free check by those providers as an incentive and approbation of your willingness to become waivered. This process on slide 13 and 14 is for those that are seeking to become waivered in the future, but will need the capabilities to provide buprenorphine to up to 30 patients. So really interesting issue. And I did just read that the RHC money was available even earlier this morning. I just verified that was there. So in addition to the complicated issues that, of course, we can get into in a full class with these issues, what I wanted to do is also identify from the National Council for Mental Well-Being and the Opioid Response Network. They have a checklist. Now, I'm just pointing out a couple questions here from the financial and regulatory readiness side, but it does have a little checklist dealing with kind of coding and billing issues that you can use. By the way, you can use it for overall grant processes as well, clearly making sure you meet Project ECHO's requirements first, but this is a general guide. And in this case, identifying the need for understanding how long you can get medication-assisted treatment covered for. What about patients that are not able to pay if their insurance company does not pay for the drugs that are needed? And what types of formulations are covered, be it an injection, or is it a dissolvable pill, or a kind of a dissolvable sheet? And you can use that to help get an understanding about your readiness and sustaining and maintaining your plan there. So we really need to recognize, folks, that even though Medicaid often puts information in the Medicaid behavioral health side, if you are a medical provider providing medication-assisted treatment, because the diagnoses we use start with the letter F, they tend to put information for you on the primary care side of things in the behavioral health manual. So I've had numerous folks in numerous states say we've searched for, any rules related to substance and opioid use, but they weren't looking in the behavioral health billing manual. They were looking in the medical manual. And don't be surprised when you still see various carriers do things differently than their guidelines apply. So work very carefully with your state rural health and primary care associations to overcome any of those particular Medicaid issues, including whether or not other types of providers may be authorized, or they may be a valued member of the clinical team, but they may not yet be, quote, reimbursable. And so in order to help give you a scan of what types of providers, for example, I'm assuming some of you, and I'm in Atlanta, by the way, I almost said y'all again. I hope I can get away with y'all, but I'm assuming some of y'all use the peer support services or peer recovery coaches. Individuals who may not have a formal clinical licensure, but have been through substance and opioid use disorders, and they want to be a member of the clinical team. Well, one of the codes I'll share with you towards the end of the presentation, and I'll just give it to you here now, H0038, is the only code that I'm aware of. Now, in this case, again, it's an H code, so it's only possibly used by Medicaid. That's the only code that we've been able to find that might cover them. But in identifying various, quote, non-licensed substance use disorder workforce, this document will give you the ability to search Hawaii. And what they did is they reviewed your provider and billing manuals, they reviewed your state regs and other public documents, and that might give you a little perspective, not only on the past, but maybe on your future. And so for those that are specifically RHCs or FQHCs, a brief reminder to those that are in the fee-for-service world. For anybody that's in a rural health clinic and an FQHC, we don't get paid fee for service like most of you do if you operate in a traditional Part B doctor's office. Rather, we get paid what some people call a per diem. All right. I don't like calling it a per diem. I like calling it a valid encounter, because there are scenarios, believe it or not, where an RHC and an FQHC can get more than one per diem on the same patient on the same day. One of those exceptions is if you do both a medical encounter and a mental health encounter on the same patient on the same day. But for each, that medical encounter and behavioral encounter, we have to meet these 4 pillars of billing before we can expect to get reimbursed. In an RHC, you're what's called the all-inclusive rate, and in an FQHC, what they call their prospective payment system rate. Well, bottom line, we have to have a face-to-face visit with an authorized provider that meets, yes, sarcastic air quotes intended, that meets medical necessity guidelines, and that it be performed at an authorized location. Well, we always don't just teach on the rules here. We need to focus on the exceptions. There is an exception when an RHC and an FQHC can receive their EPS rate, okay, their encounter rate. Same with the rural health clinic, they can get their all-inclusive rate, and I'll type it in the chat box. And that is if you're providing what's called a distant site mental health telehealth visit. And my typing is probably messing up. Well, I got pretty close there. But if you're performing a distant site mental health telehealth visit, which was what I intended on typing, that was a big change in 2022 for you. And that is the idea that you're going to report that using the same code you would have reported had you done it in the office, rather than the G2025 code that we're using for our medical distant site telehealth visits. That code went away for us on the mental health telehealth side. Again, we said we've got to notice there's different types of providers. If you need to understand whether or not or when a psychiatric diagnostic evaluative interview is reimbursed, how often should mental health or behavioral health visits be reported, whether they're insight oriented, behavior modifying, or interactive. The link that I'm kind of indicating there under number 3, and I'll try to get rid of some of the ink so it doesn't get too confusing, is a link to the Medicare coverage database. All right, now its use in relation to substance and opioid use disorder is somewhat limited, but that's where you can find the answer on what CMS considers, quote, medical necessity. Please remember, if you're in an RHC and an FQHC, that not only is your office deemed an appropriate location to receive your encounter rate, but so are patients in nursing facilities, even certain homebound restrictions, etc. And so all of that information, if you needed a background, comes from the CMS Benefits Manual, Chapter 13, Section, I think it's actually 40.1. And any RHC or FQHC instruction that we give really focuses on chapters 9 and chapters 13 of the benefit and policy manual section there. So in terms of resources, I encourage you to keep up with that. Now, I've kind of got to push forward on this issue. I know some of you thought you could get away from a claim form for at least 1 hour, but you can't. They're everywhere, no matter where you go. But I do want to point out how vital it is for any of you reporting. Watch what I'm adding, please, on the left-hand form. Where those diagnosis codes go when you're just a regular doctor's office reporting a claim to commercial insurance, or you're just basically expecting a fee-for-service payment. Well, there's room for 20 different diagnoses there, and unfortunately, managed care has given providers the mistaken and incorrect idea that your providers are supposed to give you in coding and billing every single diagnosis that patient has, even if it wasn't treated today. Managed care has some interest in doing that, and there are appropriate times where that needs to be done. But when you're performing your substance and opioid use disorder services via medication-assisted treatment, folks, please be sure to only include the diagnoses that were documented on that date of service. Now, the key is how you link them together underneath that yellow star. I'm going to show you an example in a little bit. So if you're a traditional, regular, everyday doctor's office and you have a mental health encounter and a medical encounter for Matt, each provider sends their own claim. But wait a minute, those of you in rural health and community health, we use a completely different form, normally only associated with hospitals, and that's the UB form, where I list up top, well, here's what we did. Everybody, all medical providers, all behavioral health provider services on that same date, all need to go on one claim form. All of the diagnosis codes from all providers seeing the patients go on the bottom, and look at this. Never the twain shall meet. We don't have to link them. We can't link them. As a matter of fact, you don't even have to put the national provider identifier number of providers on a UB form. It's not required. So if I'm going to look at slide 20, where I have a patient that has opioid dependence and depression, the key is it doesn't really matter what order they go in up here in block 21, but you better believe what matters is which diagnosis code you're linking as being primary. In this case, the medical provider giving us a shot for opioid use disorder or alcohol disorder maybe. If I use the diagnosis of depression as the first diagnosis, almost assured it's going to be denied because they don't want primary care physicians doing mental health as the primary service. Now, the reason I gave the injection was clearly opioid dependence, but had I switched these, had I flipped the flop here, and had I put depression as the primary diagnosis, no problem. But I would have to make sure to flip the diagnoses being linked down at the bottom as well. That, in my opinion, identifies near 50% of the medical necessity denials that a traditional doctor's office sees in my 28 years experience. Again, I don't care what order they go in up here. I care about the order they're brought down low. Now let's look at a similar claim for a mental health provider who did, I think this is the 30 minutes of therapy, and they performed another health and or behavioral assessment. Now, the good news on this one is if the medical provider had his or her documentation completed the day after the encounter, I can get their claim out of the door. Mental health, maybe they had, some things to do and couldn't get the note completed for a couple days, no big deal. We can send that claim out later in the week. But look what happens here. I need to make sure that depression is going out as the primary diagnosis. Had I used A, B, indicating that opioid dependence in this case, uncomplicated, is the primary reason we did the mental health visit, that service will be denied. Now, I didn't perform this health and behavioral assessment for opioid dependence or depression. That was done for screening for other mental or behavioral disorders. So the communication between providers and whatever EHR and IT billing system you're using is absolutely tremendously important, because if I'm in an RHC, folks, everything's going on the same claim form. We can't get into the details with this session that we have today, but they use modifiers in an RHC that the rest of us don't see. But notice, in addition to the medical office visit, we give the injection, but the therapy codes from the mental health provider are listed here, and 2 encounters should be paid, but I don't need to link my diagnoses. Now, FQHCs, when I said that they have kind of some wacky billing rules, they do. They have some of these codes in red that need to be added, a whole different subject for a whole different day. But notice the coordination I have to have in my office for the previous example and this one, and that is I have to have all of my documentation completed before I send my bill out. I would very, very much discourage y'all from billing for a note that has not been closed and authenticated. And so again, in this case, that's how that claim is going to go out. Should get to encounter rates for those of you that want to get any more information on those claims issues, the differences between the 837I form and the 837P form, etc. I wanted to give you access, as I hope you've noticed I've done the entire session, to give you access to the source documents that we use for all of the work that we do. So some sample codes here. I'm going to start flipping ahead a little bit more quickly in anticipation of time. However, you'll notice that what I've gathered on the left-hand side here are some sample medical codes that may be used. You heard me mention the insertion, removal, or reinsertion of a non-biodegradable drug delivery implant. Although I've had that code up and been doing this for a while, still haven't found folks doing that. Of course, the patient agrees to random and routine drug testing, whether that's qualitative testing or quantitative testing. Those codes, that coding kind of takes care of themselves, your injection codes, your E&M codes, etc. But there are some of those G codes on the side I'd like to point out for you as well. So if I'm reporting that I'm giving an injection, well, of course, I need to identify what I injected. And one of the things we've seen in some cases is that practices not focusing enough on the dosage of the J codes. Some of these are going to be reported at multiple units. And in addition to having your giving a shot code and what you injected, same idea would be here with the implant, should that come down the road. But more importantly, at the very end of the presentation, I'm going to do a quick little overview of what are called virtual communication services. Now, virtual communication services are going to be very, very different from traditional telehealth. So what I've done is given you some of the coding options here to include O210, O212, and some other options depending upon the carrier you might be reporting claims to. Same idea if you're on the medical side, to distinguish the fact that you're doing this visit for substance or opioid use. You may find some value to different carriers of modifiers HF or HG, so you can distinguish your medical visits from other medical visits. Behavioral health, pretty small list of codes. This covers a lot of what they're doing. So maybe they're performing a psychiatric diagnostic evaluation, or they're performing traditional psychotherapy. Please don't forget about the possible option of adding code 90785. By the way, that code has over a full page of information in the CPT manual about how and when it may be used. But if you have a patient with dementia, or that you have to use a translator, the bottom line is 90785 is an option for providers when they have to use toys, dolls, physical aids, or interpreters, etc., to quote, overcome barriers to communication. So we want you to be aware of all options there, including the ones on the bottom left. Just like our folks that are on the medical side report what's called chronic care management on a monthly basis for a lot of those things you're doing in between patient visits. Well, these codes are used for a medical provider that's overseeing the patient's mental health plan. And as long as you're meeting either 20 minutes or 60 minutes, and there's a couple different details that would need to be reviewed in there, there's reimbursement for your work in monitoring, revising, updating, and modifying a treatment plan between those visits, in addition to some G code options on the right-hand side and possible Medicaid H codes that are there. So as I wind my way down, and I obviously remain here as long as needed, if you have a newer insurance company out there, check with your payers on codes G2086 through G2088. Medicare, to my knowledge, is not necessarily reimbursing these now, but since these don't begin with an H and they don't begin with a T, they could work with just about any carrier out there. And notice the more simplified billing, very similar to what we'll see down here in a minute with how some OTP, opioid treatment programs, OTPs, a very specific designation, how they get paid on a weekly basis. But that might help smooth out some of the billing process, and it includes the treatment plan development, the therapy, and the counseling, etc. So if you have colleagues in an emergency department, you'd let them know about the add-on code for initiating OUD treatment. For anybody, if you're giving your patient a take-home supply of methadone, buprenorphine, or oral or nasal naloxone, I give you these add-on codes and encourage your more full review of some of these G codes and others that may be good options for other payers. Similarly here, as I promised, to give you some H codes that may be needed by Medicaid. Of course, for myself not being an expert on Hawaii Medicaid, I would ask you, for example, if you have what some folks call an intensive outpatient program, where you have your patient coming in at least 3 days a week, 3 hours a day. Notice code H0015, that may be an more appropriate code, better reimbursing code, bottom line, for that intensive outpatient program. There's H0038 that I mentioned earlier, maybe using for peer support services, as well as observing the patient taking their medication, and some other time or per diem based codes. So what I want to do from this point forward, in anticipation of your questions, is show you that I gave you more information than we possibly could go over. And I did that on purpose because I'd love for you to be able to review some of the T code options you may need with Medicaid, as well as opioid treatment programs, giving you a little bit of an insight into how various facility types report their services, in this case, via a weekly bundle, and down the road, who knows, maybe that comes to us in RHCs, FQHCs, or even traditional offices down the line. That reference should give you a little heads up. So knowing that time is getting tight here, folks, what I did want to do is encourage awareness that at the bottom here, if documented drug use is not treated, and if it's not noted as affecting the patient's physical, mental, or behavioral health, do not code it except in pregnancies. Examples across the nation now are where there's recreational cannabis. If it's not treated, if it's not noted as affecting the patient's physical, mental, or behavioral health, you don't code it, except in pregnancy. So of course, if the patient has a septal ulcer due to cocaine use, you would include those other codes, in this case, tachycardia due to methamphetamine use. So when I earlier mentioned the DSM-5, these are the questions in this case for opioid use disorders. They have a similar list for substance use in general, but based on the patient's findings, if they have at least 2 of the items below, your clinicians are likely reporting and indicating that there is a, quote, use disorder. But when we look at the changes that we went through from the ICD-9 to the ICD-10, boy, I tell you what, your clinicians, when they moved from the DSM-4 to the DSM-5 back in around 2015, the DSM changes don't necessarily marry up that well with the ICD-10. For example, underneath where it says criteria and terminology, the DSM-5 does not separate the diagnoses of substance abuse and dependence, but guess what? The ICD-10 sure does. So there are differences, and we want your providers to be aware of it. I hope that the American Psychiatric Association little link that I've given here will help bridge that gap a bit. Here is from the ICD-10 guidelines themselves, as I'm always giving you the sources from section 1C on what you would do if you find both words, use and abuse, in a note, or abuse and dependence in a note. There's a very important hierarchy here below. If both use and abuse are documented, only code abuse. If abuse and dependence are documented, only code dependence. And so this is kind of the foundational issue related there. But as you heard me earlier mention that providers may often add the words mild, moderate, or severe. Notice in this case that we're confident in this kind of a translation little tool here that mild use disorder can be coded as abuse based on the number of symptoms found on that list a little while ago. Moderate and severe could be coded to dependence. And a very, very careful attention to diagnosis codes is important. Okay, so please don't forget that the days of, hey, tell me what you did and we'll get paid, are quickly moving to tell me how your patients are doing and you'll get paid. So proper application of some of these diagnosis codes deal with a very important subset of diagnosis codes called hierarchical condition categories that themselves can change the per member per month payments that either you're receiving or the payments the insurance companies are receiving. So you'll see more and more of a focus on the accuracy of diagnosis codes, most specifically with Medicare and Medicaid. And so as I share this slide on 38, Ms. Summer, I think I just need probably about 2 more minutes just to give these last couple slides. Really go into your most recent version of the ICD-10, please, because this is the diagnosis that I've spoken to many folks in different states that they're not, and the folks I'm talking with, some of them, they're not on the coding and billing and documentation side. They're on the data side. And this is the only diagnosis they see. And when I show them that there are codes for with intoxication, with perceptual disturbance, with psychotic disorders, delusions, hallucinations, or sexual or sleep dysfunction, that's the kind of data they're truly seeking out. So using an uncomplicated or unspecific diagnosis tends to get claims paid, but doesn't paint that picture that our data and outcomes folks need access to. So I'm not going to read each of these items, but rest assured, folks, on the next 3 or 4 slides, I've taken each of the categories from F10 to F19 and have given you some tips on whether it's an alcohol disorder or opioid disorder or cannabis disorders, some information related to those diagnosis codes you might find interesting or important, whether it's sedatives, anxiety disorders, cocaine, or other stimulant related disorders, of course. We have substance-specific diagnosis codes from hallucinogens to nicotine dependence. So you see that I wanted to give you a lot more information than I could possibly read. Definitely to point out some issues like polysubstance dependence being removed in the DSM manual, but still being present in the ICD-10 manual. So examples that you might find beneficial comes from another book that I kind of keep here beside with all my other coding books. And it's Miss Bernard literally wrote the book on diagnosis coding, and she has some great examples on how to turn, quote, what she calls non-specific documentation into specific documentation, and that's going to help with important coding there, as well as making sure to report your social determinants of health. If the patient is it's documented that they might have difficulty overcoming their addiction because they live with other users, there are diagnosis codes that can be impactful, not only on your evaluation and management codes, but on the needs of your grant projects to help identify how any social or economic issues might be impacting their care. So I know folks have to leave. I want to give you another summary there. I love sharing my resources from, in this case, the American Society of Addiction Medicine, who has an interesting toolkit that mirrors much of what we've talked about here. And I'm just going to leave you the telehealth information and the distinction between telehealth and virtual communications. I leave that to you, but if you have questions on telehealth or on any of those updates like I referred to earlier about mental health, telehealth updates for those of you in RHCs and FQHCs, I've given you a couple slides with great resources, other options to use for virtual check-ins. Miss Summer, I defer back to you for comments, questions, and or case studies or questions. I think we should all just blame the Google folks who did not take into consideration that that we change our clocks every now and then. And for those that were impacted by me being a few minutes late, Google didn't take the move to spring forward or launch or fall backwards into account. So my apologies for that brief confusion. Ms. Summer, on behalf of the RCOR training and technical assistant leads, JBS International, and the company I'm with, Archprocoding, I thank you for the chance to speak and encourage any questions now or via email down the road.
Thank you so much, Gary. Thank you for those of you who are able to stay on. If you have any questions, feel free to unmute or put your questions in the chat. We also have Gary's slide deck on our website. So all of this great information, his contact info, and those last slides with all the resources are also up there on our ECHO website under resources and behavioral health. So you can find it there. If no questions right now, always feel free to shoot me an email and I can pass it along. Gary, lots of thank yous in the chat, and thank you for being there and answering your phone.
Yeah, I was going to throw a collar on, but hey, like you said, you're pretty casual in Hawaii. Everything works out well.
For sure. And
from somebody's in Palau. Oh,
yeah,
you can't fake goosebumps. That's awesome. Like literally halfway across the world. Fantastic. Well, hey, if we can, if the full 4-hour program is something that folks are interested in, Lee Chapman and JBS International and your RCOR technical expert leads can reach out and find if that's important. And for those of you, I noticed that Project ECHO, of course, is part of the State Rural Health Association. We're really proud to provide services to RHCs and so forth as well. Guam as well. I will start paddling now if you want the class in Hawaii.
That doesn't sound too bad, huh? You can come and check out our lava flow.
Yeah, hello. Well, and the sister volcano there's rumbling a little bit.
Yeah, she erupted yesterday morning. Yeah.
Well, but Kilauea down the road, they share the same magma flow, and you're getting some rumbles over there.
Oh yeah, Kilauea hasn't stopped, so now we have both of them, and Mauna Kea has snow. Yeah,
that's what I missed. All right.
Thank you, everybody. We'll see you next week. Dr. Bailey will be here, speaking on medical conditions manifesting as mental health conditions. So mahalo, everybody. Have a great week. Thank you, Gary. Thanks
Thank you,
again.
everybody, as well. Thank you.